Hi, this is Jenna Khan again, talking about gynecologic malignancies. An overview of radiation oncology is that there are three pillars of oncologic treatment. There's surgery, radiation therapy, and systemic therapy. And you'll see that as a theme throughout all of the subset of diseases. When we treat with radiation for cancer, we use many different words, and I'm sure that you've heard some of them already. Definitive means to cure the disease, and that is in cervical cancer, lung cancer, head and neck cancer, prostate cancer, lymphoma, and more. Adjuvant means in conjunction with other therapies. You might see that in rectal cancer, in breast cancer, esophageal cancer, some of the gynecologic cancers. Palliative is usually for decreasing pain or quality or improving their quality of life and potentially preventing future problems. We've talked about that in our previous lectures. And approximately 50% of all oncology patients receive some form of radiation. So we're going to talk a little bit about some of the gynecologic malignancies, including cervical cancer, endometrial cancer, and vulvar cancer. We'll start off with cervical cancer. It's the third most common malignancy in the world, second most common malignancy in women. It's the leading cause of death in women for developing world, and the 12th most common malignancy in the US. That usually is in underserved populations that are disproportionately affected by this cancer. You can see this trend in the rates of death, and this is cervix and endometrial cancer. So you can see, back in the 1930s, how high that rate was and how that rate has really decreased in more modern times. We have to attribute some of that to screening. So screening guidelines for patients aged 21 to 29 is for a pap smear every 3 years. HPV testing is not recommended in the ACOG guidelines for those ages. From age 30 to 65, you can have a pap with an HPV test, which is co-testing every 5 years, which is preferred method, or a pap test alone every 3 years. And once you get to over 65, no further screening if there's no history of moderate severe dysplasia and you've had 3 negative paps in a row or 2 negative co-tests in a row within the last 10 years. HPV vaccination does not alter any screening recommendations. So what is a pap smear? You'll probably learn about this more in your OBGYN rotations, but a pap smear is simply, we use this brush and scraper to get some of the cells along from the cervix, and that is tested for cytology as well as staining. So in terms of epidemiology, we talked about how this is the leading cause of cancer-related deaths among women in developing worlds. In the US, we see about 4,000 cases deaths annually from this disease. Right here, you can see a sagittal view of a female pelvis. This is the bladder, the uterus. You can see this is where the cervix is. This is the vagina and the rectum. This is the cervix, and here is the os. Here is an abnormal looking cervix, and you can barely make out the os here. So just a general picture of a normal uterus and cervix and vagina. As we talk about early stages of cervix cancer, those cancerous tissue really just within the cervix. As cancer progresses, you can see in later stages it involves more of the cervix, and more locally advanced, it can spread outside the cervix. It can cause bleeding and cause other issues like hydronephrosis. So just a very generalized overview of how we treat cervical cancer. You can do that through conization, trachelectomy, or hysterectomy, or definitive radiation. So with conization, just take a simple cone from the cervix and just cutting out those cells that are abnormal. And you can see here with the knife. There's a trachelectomy where the cervix is removed and a band or some kind of closure is placed at the bottom of the uterus to act kind of like that cervix. And so that's a trachelectomy. That's for fertility sparing. And then there's different types of hysterectomies. And while I'm not going to go into all of that, you can see here there are subtotal, total, and radical hysterectomies where they take out different parts of the uterus, the cervix. They might include the parametria, and then the radical includes some of the vagina as well. An overview of how we treat locally advanced cervical cancer is with chemoradiation, which is the preferred method. But some patients do have radical hysterectomy and lymph node dissection, and we add radiation and or chemotherapy as indicated. So this is a general overview of how we treat cervical cancer. Cis is cisplatin, so chemotherapy, and that's given weekly during treatment. EBRT is external beam radiation therapy, and that's given every day, Monday through Friday, 5 days a week for 5 weeks. And then and so you can see those lines that go with that. And then the green line is brachytherapy or internal radiation, which we'll talk a little bit more about. And that is the brachytherapy, and that is usually anywhere from 4 to 5 to 6 treatments. And that we all like to have that all done within 8 weeks. So just a general overview of why do we treat these patients with chemoradiation? So there was a study done in the 90s that looked at cervical cancer patients, and they randomized them to radical hysterectomy versus radiation. They showed that those patients who had tumors that were greater than 4 centimeters in size, so larger tumors, more locally advanced tumors, 84% ended up needing radiation on top of the surgery. And those patients ended up having more toxicity when you added the radiation to the hysterectomy. But there was no difference in outcomes when you did radiation alone versus surgery and then needing the radiation, or radiation and surgery versus surgery. So no difference, so they equaled each other. After surgery, the indications for adding radiation would be lymphovascular space invasion, deep stromal invasion, and size greater than 4 centimeters, and you need 2 of those 3. And then when do we decide to add chemotherapy? If there's positive lymph nodes, if there's positive margins, or there's extension into the parametria, and that's when we add chemotherapy to our radiation. And this is in the post-operative management. So why do we say we treat these patients with chemoradiation? One of the earlier studies showed that when we have these patients with cervical cancer and we randomize them to radiation alone versus chemo and radiation, we showed that there was an improvement in overall survival for those that got chemo radiation over radiation alone. 67% versus 41% at 8 years, and that was statistically significant. When we looked at local regional recurrence rates, we showed that the radiation alone had a higher failure rate than with chemoradiation, so 35% versus 18%. That's almost in half. So overall reduction in the risk of death or recurrence of 51%, and reduction in the local regional recurrence rate by 58% by adding chemotherapy to the radiation. There were other studies that also looked at this. So altogether, there were 5 randomized controlled trials completed in the 1990s, and the NCI issued an alert saying that chemoradiation was now the standard of care for local regionally advanced cervical cancer. And so how do we treat these patients? Just as a generalized overview, this is just, you guys will be contouring. And so at this point, you've probably seen what a pelvis looks like and how contours look like. But when we put our radiation field on, we are including the entire uterus and affected lymph node areas. This is for 3D conformal radiation, and there is more modern techniques to use IMRT for these patients, but this is more traditional ports for 3D conformal radiation for cervical cancer. So what is brachytherapy? I talked about how we do chemo radiation, and I know in most of your talks so far, we've talked about external beam radiation, but brachytherapy is another form of radiation where a radioactive source is placed into the treatment area. It's used in a variety of organ sites, such as prostate, gynecologic cancers, and breast cancer. We insert brachytherapy devices, either outpatient or inpatient, and it can be done in a multidisciplinary effort with surgical oncologists, urologists, gyn-oncs, or other surgical specialties. And we call these intracavitary or interstitial. So in gynecologic oncology, the indications for brachytherapy are in cervical cancer. It's one of, as we talked about, the primary treatment for early stage disease that's not amenable to surgery. And it is a boost after external beam radiation and chemotherapy for the curative therapy. In endometrial cancer, we'll talk more about later, is adjuvant therapy after surgery to prevent a recurrence to the vaginal cuff. And in vaginal cancer, it is also very similar to cervical cancer in the sense that it's that extra boost for curative therapy. So brachytherapy is high dose rate and there's low dose rate. The high dose rate gives a dose given off quickly from a temporary source that's placed into the patient. So an applicator is placed in the patient, usually either in the operating room or in the clinic. And an iridium source comes out of this afterloader and into that applicator. The entire procedure is usually 1 to 3 hours. And the different type of applicators are for gynecologic oncology are tandem and ovoids, tandem and ring, tandem and cylinder, tandem and interstitial. Mostly we'll just be talking about the most common ones, tandem and ovoids, tandem and ring, and cylinders. So up here you can see there's a tandem and ovoids. This is a tandem and ring. And here's a picture of how a tandem goes into the uterus and the ovoids sit into the vaginal fornices. This is what an interstitial template looks like. It's usually for larger lesions or maybe lower vaginal involvement. We usually use a tandem when there's an intact uterus. And so you can see here is the obturator, and then these are the needles that go into the patient. And then the radiation source goes within those needles. So how do we normally insert these? It can be under different types of anesthesia. It could be under just oral pain medicine. It could be under conscious sedation, spinal, like an epidural, or general anesthesia. Here is a picture of a physician and placement of a tandem and ovoid. And packing is usually placed so that that it is stabilized and helps to displace some of the normal organs. Then we plan the radiation, and you can see here more of an old school planning to different points. Here on the right-hand side, you can see a tandem and the actual disease that we're trying to cover, and the isodose lines that are covering that disease. Here's another picture of what that looks like when placed into a patient. You can see the tandem here, and that's into the uterus. This is more of another picture of an interstitial treatment for an advanced cervical cancer case. The yellow is the bladder. This is where the tumor is, and you can see all the needles placed in there. And here is the rectum. So you can see where we can distribute the dose just to the tumor itself. A vaginal cylinder looks like this, and it's placed into the vagina, and it's to treat part of the vagina where you're at higher risk of a recurrence. And we'll be talking about endometrial cancer, but that's one of the more common uses of this vaginal cylinder, where we treat the vagina to make sure that the cancer doesn't come back into the vaginal canal. This is the afterloader again, and how it connects to the patient's applicator that's in them, and the radiation source goes from the afterloader and travels through into the patient. And then it goes back in and it comes out, and it goes back out to a different part of the applicator. Next, we'll talk about endometrial cancer. It's the most common gynecologic cancer. It's the fourth most common malignancy in women. There's about 55,000 new cases a year, and 7% of cancer in women. It's the seventh most common cause of cancer death. This is just a general overview of the staging. We didn't go through cervical cancer staging as in depth, but this kind of gives you an idea of the FIGO staging that has recently changed for endometrial cancer. In radiation, the important things for us to think about are if it's confined to the uterus and how much of the uterus is involved, and if the cervix is involved, and then if it has gone outside of the uterus. As we look under the microscope after a hysterectomy for these women, we look at the grade of the tumor. And we look at the depth of invasion, if it's at the inner, middle, or deep part of the uterus. And that gives us a good indication of the incidence of pelvic nodes. So as the grade of the tumor increases and the depth of invasion of the tumor increases, the rate of pelvic lymph nodes increases as well in endometrial cancer. And that's how that's one of the indications for what type of radiation we're going to give to these patients. So when we have patients with early stage grade 1 or 2 tumors, we don't think as much about worrying about the incidence of their pelvic nodes. We think more about their vaginal cuff being involved or a recurrence of their vaginal cuff. Whereas if you have a patient who has more of a grade 3 tumor with a deep invasion, we worry more about the lymph nodes in the pelvis and might want to cover those as well. This has been looked at in different studies. And so some of the early studies showed that in early stage intermediate risk endometrial cancer, we want to give radiation. And then when that was broken down into if we should give radiation to the entire pelvis versus just the vaginal cuff, we found that brachytherapy to the vaginal cuff could be the treatment of choice for patients with intermediate risk endometrial cancer. When we think about higher stages in endometrial cancer, we treat them with a combination of chemotherapy and radiation, and that can be very varying per institution and per patient, but some type of combination of chemotherapy and radiation. Lastly, we'll just touch briefly on vulvar cancer. You can see here the vulva, and I always say vulvar cancer is very similar to anal cancer. Anal cancer that is HPV positive and squamous cell carcinoma. So the management of a primary vulvar cancer is either, well, one of them is radical vulvectomy, where they really take a huge amount, the entire vulva, and it's very morbid. There's a lot of poor wound healing, lymphedema, decreased quality of life. And so now there's a move towards radical local excision, and that's a excision of the primary tumor with a 1 centimeter clinical margin. And there really has been no difference in disease-free survival or local recurrence with this radical local excision. But traditionally, when tumors are very large, they required a pelvic exenteration. And again, their perioperative mortality was pretty high. And post-op morbidity, including colostomy and urinary diversion, was not pleasant. So alternative treatment options include giving neoadjuvant or prior to surgery chemoradiation, or just definitive primary chemoradiation to these tumors. Here are some contouring guidelines of how we treat that disease. And here is the vulvar disease, and this red line is kind of where we would be contouring, and then including some of those lymph node areas as well, but the main disease being in this red area. What are some of the side effects of radiation for gynecologic malignancies? So up on top is the short term, on the bottom is the long term. On the left-hand side is the more likely, and then the less likely on the right-hand side. These patients usually have diarrhea, urinary discomfort, and urgency during treatment. We will put them into menopause once we start our radiation. Patients of any type of radiation treatment, one of the side effects is fatigue. We can also cause skin redness or irritation, especially in those patients with vulvar cancer. Cause rectal urgency. We can cause blood in the urine or blood in the stool. Some of the long-term side effects include infertility, early menopause, vaginal stenosis or narrowing, decreased vaginal secretions or dryness, which we combat with vaginal dilators, which we give to patients a few weeks to months after they finish their radiation, so that we can combat the vaginal stenosis and narrowing. Patients can continue to have loose stools or diarrhea, as well as rectal urgency, and some of those effects with urination, but those do seem to improve over time. Less likely side effects include fistulas, but those can happen, strictures in the bowel or vagina or urethra. We can cause pelvic insufficiency fractures or fractures in the bones of the hips, swelling of the lower extremities called lymphedema. And so those are some of the side effects. And so we do have some medications when we are treating these patients to treat and fight that, and do go through those with patients on a weekly basis. That was an overview of gynecologic malignancies. If you have any questions, please feel free to reach out. Thank you.